So in talking about the liver, we're going to first talk about anatomy. We'll talk then about grayscale characteristics, and then we'll go into the measurements. So the liver is made up of 3 lobes, as we all know, the right, left, and caudate lobe. And the right lobe is further divided into anterior and posterior segments. And the left lobe is further divided into medial and lateral segments. Now, Rydell's lobe, which our hair talked about, is not really a lobe of the liver at all, but rather a thin extension of the inferior tip of the right lobe of the liver. And this is more typically seen in thin women. In talking about the liver, we are going to be talking about hepatic veins. We're going to talk about how they divide the liver into various segments, looking at the right hepatic vein, middle hepatic vein, and the left hepatic vein. So the right hepatic vein is going to course between the anterior and posterior segments in the liver within the right intersegmental fissure. So here's the hepatic vein, anterior segment, posterior segment of the liver. And the left hepatic vein courses between the left medial and lateral segments and courses in the intersegmental fissure on the left, dividing the medial segment from the lateral segment. And the middle hepatic vein is going to course in the main lobar fissure, also called the interlobar fissure. And this separates the right lobe from the left lobe, and more specifically, the anterior lobe of the right lobe from the anterior segment of the right lobe from the medial segment of the left lobe. So as we just discussed, the hepatic veins separate the hepatic segments. They're intersegmental, and they're also intralobar as the middle hepatic vein. And the portal veins are going to course through the segments, intrasegmental. Now, it's important to differentiate the portal veins from the hepatic veins, and how we do that is we look for the echogenicity, the periportal echogenicity, which is related to fibrofatty tissue in the periportal region, and we also look for adjacent hepatic arteries and biliary ducts. So here you can see that this is going to be a portal vein. It's got adjacent echogenic fibrofatty tissue as opposed to a hepatic vein without. So going through evaluating more of the anatomy of the liver, looking at the fissure for the ligamentum venosum. And this is important to look for because it separates the caudate lobe from the lateral segment of the left lobe. It's going to be the anterior border of the caudate lobe, with the IVC being the posterior border of the caudate lobe. The interlobar fissure, which we've already discussed a little bit, also called the main lobar fissure, is going to separate the right and left lobes, but more importantly, it identifies the location of the gallbladder fossa. And if you remember, we talked about the middle hepatic vein coursing within the interlobar fissure. So if you have a small contracted gallbladder, you've got a gallbladder contracted around stones and you're having trouble finding that gallbladder, if you can find the interlobar fissure and the middle hepatic vein, then that should direct you to the gallbladder fossa. The ligamentum teres is another landmark that's important to identify, and that courses between the medial and lateral segments of the left lobe, as shown here as this echogenic structure. And the fibrous remnant of the umbilical vein is within this ligament. So any discussion of the liver needs to include Cunard's anatomy, or Cunard's system as it's sometimes called. And this is quickly becoming the universal nomenclature for hepatic lesion localization. It's important to identify and be aware of this anatomy in speaking with your surgical colleagues. And what it is, it's an anatomic basis for surgical hepatic segmental resections. It's based on portal segments. And importantly, each segment has its own blood supply, including the hepatic artery, hepatic veins and portal veins, lymphatics, and biliary drainage. And within each of these Cunard's segments, there'll be a portal vein or portal vein branches centrally bordered by hepatic veins. And so that's the importance, one of the importance of reviewing the hepatic vein, portal vein anatomy. So in this system, there are 8 subsegments. The left lateral segment, the right anterior segment and posterior segment are all subdivided into subsegments with both a superior and inferior subsegment. The caudate lobe, and for the most part the left medial segment, are maintained as a single segment. So in talking to the surgical colleagues, or when you want to describe where a lesion is in the liver, segment 1, you refer to the caudate lobe. Segment 2, left lateral superior. Segment 3, left lateral inferior. Segment 4, left medial, and sometimes you'll see in the literature, some people will talk about a 4A and a 4B. 4A referring to a superior subsegment and 4B inferior. 5 is anterior inferior, right. 6 is right posterior inferior. 7, right posterior superior. And 8, right anterior superior. So in looking at the liver, again, we're going to focus here on the hepatic veins, and the hepatic veins divide the liver longitudinally, as we talked about, into 4 segments. The portal veins are going to divide the liver further, divide these segments further in a transverse plane along the left and main portal veins. And that's just another example of depicting the portal veins transversing the liver and creating subsegments of the segments. So echogenicity of the liver. The liver is homogeneous in echogenicity, and it has fine low-level echoes. When we talk about echogenicity of a structure, we talk about it relative to other structures, either adjacent structures or others. So in talking about the liver, when we compare it to the pancreas, it's going to be hypoechoic or isoechoic to the pancreas. It's going to be hyperechoic or isoechoic relative to the right kidney. And it's always going to be hypoechoic to the spleen. So looking at images, we've got the liver adjacent to the right kidney, and you can see that the liver here is hyperechoic relative to the right kidney. Left lobe of the liver with pancreas. Left lobe of the liver is slightly hypoechoic to isoechoic with the pancreas in this image, and we'll see that that can vary. It's examples of liver with the spleen. Probably this one, the better one. The liver is going to be hypoechoic to the spleen, and there are times when the left lobe of the liver can get quite large and wrap around the spleen. And because it's hypoechoic, it sometimes has the appearance of a subcapsular hematoma. This can be easily differentiated by putting some color on, showing the normal vessels in the liver. So the length of the liver at the midclavicular line is the most commonly used measurement for evaluating liver size. And various studies have found a range of normal for the length of the liver. And variations in length can be due to different body types, BMI, and gender. Here's an example of a liver, length of the liver being measured in the midclavicular line. Sometimes we're not as lucky and able to find the most superior and inferior aspects of the liver. And real-time extended field of view scanning can be very helpful in that respect in trying to get an accurate measurement. So a study by Kratzer et al. Performed in 2003. It looked at 2,080 subjects, pretty much equal male, female, with quite a wide range of age. And they looked at prospective ultrasound exams. And they found that the average length of the liver at the midclavicular line was 14 plus or minus 1.7 centimeters. The mean length for men being slightly larger, 14.5 plus or minus 1.7 centimeters. And the mean length for women, 13.5 plus or minus 1.7 centimeters. 11.5% of their subjects, the liver did measure greater than 16 centimeters. But they concluded that the measurement of the liver at the midclavicular line of 16 centimeters or more should be considered enlarged. And what they found was the BMI and the height were the most important factors influencing size. We're going to move on to discuss biliary ducts. And again, we're going to start with anatomy, looking at the right and left hepatic ducts, which join to form the common hepatic duct. And the common hepatic duct is going to be located anterior to the right and main portal veins. The distal cystic duct joins the common hepatic duct posteriorly and forms the common bile duct. Now, the cystic duct junction with the common hepatic duct is not seen in every individual, and therefore people will sometimes refer to the duct as the extrahepatic biliary duct. And by that they include both the common hepatic duct and the common bile duct. Here's an example of proximal common bile duct at the porta hepatis, coursing anterior to the right and main portal vein and the right hepatic artery. Another example of the common hepatic duct where we can see it all the way to the pancreatic head. In talking about the common bile duct, we use the terms proximal and distal. And proximal refers to the segment of the duct in relative proximity to the liver, and distal refers to the more caudal aspect in relative proximity to the bowel. Now, the proximal duct, typically, as we said here, is anterior to the portal vein, right and main portal veins. The distal duct can be further distinguished into the suprapancreatic and intrapancreatic duct, with the suprapancreatic portion being between the porta hepatis and the head of the pancreas, and the intrapancreatic portion being within the pancreas. So the suprapancreatic portion of the distal duct also can be considered the mid-common bile duct, and here you can see the duodenum, and the duct is passing posterior to the duodenum. And the distal common bile duct is going to enter the head of the pancreas. We can see it here, and in transverse image see it here at the head of the pancreas, and courses along the posterior aspect of the pancreatic head. The right and left hepatic ducts, also referred to as first order branches, are routinely going to be seen by ultrasound. The second order branches can also occasionally be seen, but we shouldn't be seeing on a routine ultrasound visualization of third or higher order branches. The normal diameter of the first and higher order branches is 2 millimeters or less, or another way to look at that is that it should be no more than 40% of the diameter of the adjacent portal vein. So the AP diameter of the common bile duct is going to be measured in the long axis of the common bile duct as depicted here in this image. And the lumen is going to be measured from inside of the near wall to inside of the far wall, so we're not going to include the wall in our measurements. And the measurements of the common bile duct can be made in various locations. It can either be a specific location, for example, at the porta hepatis parallel to the main portal vein, can be measured anterior to the right portal vein, in the portion of the duct where the right hepatic artery crosses the common bile duct, or in the suprapancreatic portion of the duct prior to where it tapers at the pancreatic head. And it also can be measured at the largest visualized diameter. One of the problems with measuring the largest visualized diameter is that we don't often see the entire duct in everybody, and therefore we don't know where the largest diameter is. If you're going to measure the common bile duct at one of these specific locations, it's important that you're consistent in your lab so that you can have consistency between patients and within patients on follow-up studies. These are just examples, again, looking at the common bile duct and looking at various areas where the duct is being measured. Now, the common bile duct will typically vary in diameter along its length, as we can see in this image here, where it gets increased slightly more distally towards the pancreatic head. So when we look at our bile duct measurements, it's important to note that there is observer error of 1 to 2 millimeters. And that's pretty significant when you think these biliary ducts, they're small measurements for the most part to begin with. And there's also respiratory variation which needs to be taken into consideration, which has been found to be greater than 1 millimeter. So threshold measurements that we typically use, the upper limit of normal was found to be 6 millimeters in many studies. Now the literature is inconclusive with regard to whether there is a normal increase in diameter of the common bile duct with age. We've all heard the 4 for 40, 5 for 50, 6 for 60, etc. But the literature is inconclusive. One group here found a correlation between age and common bile duct diameter, and they concluded that in normal patients greater than 65 years, that it can measure up to 10 millimeters. And another group reported similar results where they looked at asymptomatic patients greater than 75 years. Now the literature is also inconclusive with regard to an association between cholecystectomy and a large common bile duct. So this group studied 59 patients with normal diameter ducts at the time of cholecystectomy. And they evaluated these ducts before cholecystectomy, 3, 6 months, 1, and 5 years post-cholecystectomy. And what they found was the majority, greater than 95%, did not have dilatation of their extrahepatic bile duct beyond 6 millimeters. Now these are patients who had normal bile ducts at the time of cholecystectomy. So they concluded that a preoperative normal extrahepatic bile duct does not dilate after cholecystectomy. Now one of the problems that we have when evaluating these patients is that we don't often know what their duct looked like at the time of cholecystectomy. We often don't have those images. So the upper limits of normal for the extrahepatic bile duct by ultrasound in healthy subjects less than 65 years should be 6 to 7 millimeters. And in greater than 65 years, it can be up to 10 millimeters, but we have to look at this with caution. Post-cholecystectomy patients with normal preoperative bile duct shouldn't be more than 6 or 6 to 7 millimeters. Now, according to Rumack et al. In their book, they suggest that although diameters up to 10 millimeters have been documented in an asymptomatic population, that the majority of ducts are less than 7 millimeters. And so they conclude that a duct diameter of 7 millimeters or greater should elicit further investigation just to make sure that that is either normal or not for that particular patient. So we're going to move on to the gallbladder. And the gallbladder is divided into the fundus, body, and neck as seen in this image. And the fundus is typically going to be the most anterior and typically the most inferior segment. The gallbladder is going to be positioned beneath the liver, adjacent to the interlobar fissure. And again, what we already talked about, the middle hepatic vein running in the interlobar fissure is in the same anatomic plane, and therefore we can use that middle hepatic vein or the interlobar fissure in order to find the gallbladder fossa when we're having trouble. Now the gallbladder can be variable in shape, and there are often many, many folds seen in the neck, and occasionally there can be many folds seen throughout the gallbladder. And when the fundus folds on itself, as shown in this image, here's the fundus with the fold here, it's referred to as a Phrygian cap. And when we evaluate the gallbladder, it's very important to make sure that you evaluate the entire gallbladder, particularly the gallbladder neck, where stones can be lodged within the gallbladder neck, and if we don't visualize that neck, they can be missed. The gallbladder wall is typically visualized as a thin echogenic stripe surrounding the gallbladder. Now we typically request a fast of a minimum of 4 hours, preferably 6 to 8 hours before evaluating the gallbladder. This is because a contracted gallbladder can appear to have a thickened wall, and it can also obscure intraluminal or wall abnormalities. So it's important to have our patients fast as much as we can. When measuring the gallbladder wall, we typically want to look at the anterior wall, and we measure it in long axis view with the sound beam perpendicular to the wall as seen in this image. So gallbladder wall thickness should be less than or equal to 3 millimeters. The length should be less than or equal to 8 to 12 centimeters. Width less than or equal to 4 centimeters. And consider high drops when the gallbladder length is greater than 8 to 10 centimeters or the width is greater than 4 centimeters.